In the abstract of the Joint International Consensus Statement for Ending Stigma of Obesity, published in the journal Nature, we find this statement. Research indicates that weight stigma can cause physical and psychological harm, and that affected individuals are less likely to receive adequate care. For these reasons, weight stigma damages health, undermines human and social rights, and is unacceptable in modern societies.
Welcome to the A&P Professor, a few minutes to focus on teaching human anatomy and physiology with a veteran educator and teaching mentor, your host, Kevin Patton.
In this Journal Club episode, Krista Rumpolsky and I discuss a paper on how attitudes about large body donors may contribute to weight stigma among health professionals. Okay, well, we're here once again with another Journal Club episode with Krista Rumpolsky. Welcome, Krista.
Hi, Kevin. Nice to be back. It's been a while.
Yeah, it has, and there's a reason for that, isn't there? You just had a new addition to your family. Tell us about that.
Yeah, yes, my son Noah was born 11 weeks ago, 4 weeks early, though, so that was a bit of a surprise and threw my winter and spring into a bit of chaos, but it's good for you, right, to build that kind of tolerance in life for the unexpected, especially for a obsessive planner like me. So I've joined the throngs of, working mothers in academia and just trying to figure out how to make it all work, as we all do. So it's been great.
All right. Well, congratulations.
Thank you.
That's great. Even if it did cause us to do some of our practice our resiliency a little bit and get going. And, we had kind of already scheduled this conversation before that all happened. And I went back and reread our article, which I'm kind of glad I had more time to let it kind of settle in, and that there is so much, like most of the articles you bring us in the Journal Club, there is so much here, so much to unpack that maybe we better start unpacking it.
Yeah.
So as usual, Krista has provided us a summary of the article so that we're all talking about the same thing and know what the essential elements of it are. And then after that, we'll come back and dive right into it.
Great.
You'll hear Krista's summary right after this quick break. A searchable transcript and a captioned audiogram of this episode are funded by AAA, the American Association for Anatomy, at anatomy.org. Did you realize that if you're already a member of HAPS, the Human Anatomy and Physiology Society, that you qualify for a deeply discounted membership in AAA? I'm a member in both organizations, and I'm sure glad I added a AAA membership to my HAPS membership. They complement one another in a lot of different ways that give me a richer basket of resources for teaching A&P, and, well, a much wider network of peers. Just go to anatomy.org and click on the membership tab in the navigation ribbon to find out about that discount.
The Difficult Cadaver, Weight Bias in the Gross Anatomy Lab. Introduction. Weight bias, defined as negative attitudes towards people based on perceptions about their weight and obesity, adversely affect the quality of patient care and can have serious implications on the doctor-patient relationship. It is well established that physicians and the general population often hold very negative attitudes and self-blaming beliefs about those perceived to have excess body weight. A 2014 study with a large sample of medical students found that 75% of students showed some level of implicit weight bias. While some medical schools and health professions programs are beginning to include lessons on or discuss weight bias as part of a more humanistic approach to medical training, the problem is pervasive in healthcare. Research has shown that individuals who feel stigmatized for their weight are more likely to avoid healthcare situations and more likely to experience poor health outcomes than those even of the same body weight who do not experience stigma, speaking to the psychosocial factors that influence the relationship between body weight and health. Since gross anatomy is often the foundational course for a future healthcare provider, with a cadaver often being referred to as the first patient, the course may be important in shaping students' early attitudes towards individuals in larger bodies and fatness in general. No previous study has examined how medical students perceive overweight and obesity within the context of the dissection experience. Therefore, the researchers in this study sought through both a survey and interviews to determine the effect of the gross anatomy course upon their attitudes towards larger cadavers and living patients with overweight and obesity. This study was conducted at the Perelman School of Medicine at the University of Pennsylvania. Gross anatomy is taught during the first semester, lasting approximately 3 months, with 2/3 of 100 hours devoted to laboratory time. The study was formed after a survey was sent to all first-year students to explore their emotional and early professional experiences during dissection. This initial survey had nothing measuring or examining weight bias, but 10 students offered unexpected, unprompted comments about weight, body image, and obesity, leading the researchers to add questions in subsequent interviews. The researchers developed a survey to explore these themes that consisted of 12 multiple-choice questions related to the anatomy lab experience and added 2 free text questions addressing body image and attitudes towards individuals with overweight and obesity. These 2 questions included, has the anatomy lab experience changed how you feel about people with overweight obesity? And has the anatomy lab experience changed how you feel about your own weight? Other questions not directly related to weight, but rather to their feelings about cadavers as individuals and previous cadaver exposure were also included. Qualitative analysis was conducted from interviews on the free text responses with these students. 319 first-year students responded to the survey between the years 2015 and 2018. Analysis of the 63 free text responses to the question, "The anatomy lab has changed how I feel about people with overweight or obesity," who marked yes, revealed that for 70% of these students, the course generated negative feelings or attitudes towards body fat or people with overweight or obesity. It generated sympathy for people or anger towards those who made negative comments about larger bodies in only 11% of students. For the second weight-related question, has the anatomy lab experience changed how you feel about your own weight? 84% indicated that the anatomy course had made a negative impact on their body image. There were no significant relationships between the 2 questions relative to body weight and age or gender in this study. 3 major themes emerged from the interview and free text responses. These were difficult bodies, unhealthy bodies, and disgust. And these themes played out across student descriptions of cadavers, living patients, and their own bodies. The authors suggest that these themes support the development of an explanatory model in which students saw the value of a body as related to the ease with which information could be extracted from it, and where students framed negative attitudes towards larger bodies as concern for the health consequences as overweight and obesity. Students repeatedly described dissection of larger cadavers as more challenging, time-consuming, unproductive, and frustrating, and that they were learning less than their classmates with smaller bodies. Despite only knowing the final cause of death and age from a tag, students came to the conclusion that obesity does, quote, so much damage to the body and, quote, physically affects all the organs. They described adipose tissue as, quote, gross, disgusting, and disturbing, and that it was everywhere. They connected the difficulty of dissecting larger cadavers to imagined challenges and frustrations faced by healthcare providers caring for patients, such as in surgery, saying, quote, surgeons don't like operating on obese people. They felt more motivated to encourage future patients to lead healthier lifestyles, and that it would be motivating for obese patients to see what they look like on the inside to incentivize weight loss. Students largely framed obesity as a controllable state that could be managed with diet and exercise, while none cited socioeconomic or biologic factors. For their own bodies, 40 students commented that the course made them worry about their own body weight and if they had too much fat. About half of the students made comments that they wanted to lose weight. Analysis suggests that students perceive gross anatomy as influencing their feelings and attitudes about fat through a complex process wherein academic pressure and classroom commentary cast adipose tissue as disgusting and dissecting larger bodies as difficult, amplified their pre-existing weight bias and body image issues. The observation that students say difficult bodies are less educationally valuable is concerning and echoes the narrative of the difficult patient. Given that weight bias poses an obstacle to the ethical care of patients, gross anatomy may be an early site of professionalism and re-education on the topic. The authors conclude that the anatomy laboratory, where medical students act upon their so-called first patients, is an important and previously unexplored potential space in the development of weight bias, and confronting the bias nurtured here may be an important component in the approach to addressing physicians' attitudes towards individuals with overweight and obesity. This study was conducted by Adeline Goss of the Department of Neurology, UCSF San Francisco, California, and by Leah Rethy, Rebecca Pearl, and Horace DeLisser of the Perelman School of Medicine, University of Pennsylvania, Philadelphia, PA.
Krista and I are going to dive into this discussion right after this short break. The free distribution of this podcast is sponsored by the Master of Science in Human Anatomy and Physiology Instruction, the Happy Degree. If you're looking for some deep discussions led by experienced mentors about factors that deeply affect the learning of our A&P students, including development of professional attitudes and practices, you need to learn more about the Happy Degree. Check out this online graduate program at nycc.edu/happy, that's HAPI, or click the link in the show notes or episode page. There's a new cohort forming right now, so now's a great time to look into it. Okay, so that article about the difficult cadaver and weight bias and weight stigma, that just opens up a lot of stuff, doesn't it?
It does, yeah. And what really grabbed me about this article was, honestly, I had a moment when I saw it that I was like, no, they beat me to it, because weight stigma and weight bias have been a research interest of mine for a couple of years now. And it really started because of my experience taking my first dissection course. And I had done some dissection before that and have certainly done a lot after, but it was being auditing a Doctor of Physical Therapy gross anatomy dissection course with the students, just to have that full experience at my previous institution, and seeing and witnessing the conversations and hearing the frustrations and things like that from my fellow, lab members and team members with having to work with a larger body and the time it would take. That really got me thinking, like, I wonder if this gross anatomy experience creates or worsens weight stigma. And, in a profession, this article is about medical students, but in a profession like physical therapy, where people have their hands, on patients, professionals have their hands on patients' bodies, arguably more frequently and for more time than any other health profession. So, there is already, an issue with weight bias in that profession, like there are with all the other healthcare professions. But how much worse does the gross anatomy experience make that bias if not addressed, in the classroom, which obviously it isn't in the vast majority of curricula. Certainly not in a PT curriculum that I'm familiar with. So that's what got me thinking. And I went down a literature search, and this was, 2 years ago. This had not been ever studied whatsoever, the relationship with gross anatomy study or dissection and weight bias. There were certainly articles examining rates of it and interventions to try to mitigate it in medical professions, in PT and other professions, but nothing regarding the cadaver experience. So when this came out, I was like, somebody beat me to it. But certainly,
Right.
hey, there's
Hate when that happens.
Yeah. And I think what's also very interesting about this paper is that it sort of came up accidentally, in that they weren't attempting the researchers had initially just had a survey about their feelings and experiences doing dissection, and there were just impromptu free text responses related to weight stigma. So the Rebecca Pearl, who's one of the authors, is a leading weight stigma researcher. And, I'm sure she had some part to play with kind of doing a follow-up, diving into that a little bit more. So I'm so glad that they published this. And, it's one study, it's preliminary, but I would love to see, start surveying more students on this type, on their experience with this. And I think it's both so important to talk about because they are future healthcare providers. So how does this impact the way that they'll see and treat patients? But as I said in the summary, this had a serious impact on this group of students' own body image and feelings about themselves. And, that's not something that we would, that I've seen talked about. So in previous papers. So there, like you said, there is so much to unpack in this article.
Right. And that I'm glad you brought up that part of the paper where they talked about how they got into this, because I think that makes it especially relevant that the students brought this up without them asking them about it. In other words, they just were looking at overall feelings and attitudes and did not ask any weight stigma related questions at first until the students start bringing it up. And then they said, oh, look at that. Let's see what that's about. And then they expanded it. Because I think a lot of times, whether it's conscious or subconscious, when we read, research on some of these issues where they take a particular, maybe controversial issue, especially involving attitudes, and then they ask about it. It's sort of like those surveys that are designed to change your mind, that they don't care what the results are. They're asking you loaded questions because they want you to vote differently in the election or whatever it is. And so this sort of laid out the fact that, hey, this is the opposite of that. We didn't go into it looking at weight stigma. We went into it not looking at weight stigma, and it popped itself right up. So I think that kind of underscores for anybody who doesn't feel like this is a thing that, it is. And in this article, examined it. And I also appreciate you bringing up the idea that, we're in a position of training future health professionals. And you talked about your experience in a physical therapy program, but any of the health professions deal with this issue. So, my experience has mostly been with students going into nursing. A lot of them went into other areas as well over the years, but at the community college, for example, most of our students are thinking of going into nursing. And it's going to exist in all these health professions. And no matter what their scope of practice is, they're dealing with patients or various clients in a healthcare setting, and this is going to impact them. So no matter who our A and P students are, or A students or P students, this impacts us. And it kind of gets to that, you talked about in the PT curriculum that you're familiar with, this isn't something that's addressed.
Yeah.
It's not addressed in the A&P curriculum that I'm familiar with. It's not addressed probably in most curricula. And maybe it will be, but that's where our role comes in, I think, as individual instructors, that we need to make sure that we're filling our course in with the things that aren't the expected standardized outcomes, that we have these other outcomes. And maybe we should state it in our syllabus, maybe not, but at least, have them in our mind and do some things that will help that. And I think as this conversation unfolds, we're going to get to what some of those things might be.
It's great that you bring that up, and we've got a long way to go. But one of the major focuses of the HAPS Diversity, Equity, and Inclusion Committee right now is working on like those hidden curriculum types of learning outcomes. And I'm on a small subcommittee for looking at weight bias and weight stigma in the A&P curriculum, and where we can develop both a better understanding of the physiologic regulation of body weight to destigmatize individuals in larger bodies, but also where can we talk about the more humanistic side of things and fuse in, hey, you are all here because most of you want to be a future healthcare professional. And like I said in the intro, like there's substantial research that shows that shaming and stigma cause healthcare avoidance, right? Not, I'm overweight, I need to lose weight. No one told me that before. Like everybody, you can, like as if it's the first time they've heard it, and that somehow shaming people for any issue is going to lead to them, lead to better outcomes for them. If shame, and I say this all the time, if shame were enough, there would be no addiction, there would be no habits. It doesn't work. It doesn't work. And then obviously, like, we're not here today to go down the rabbit hole of, well, what really is the cause of obesity, and are there problems? Like, can you be healthy and in a larger body? Like, that could be a whole other conversation, of course. But the main focus here is that stigmatizing people, right, for this issue does not lead to them having better health outcomes. In fact, it leads to worse health outcomes, whether due to avoidance of healthcare or the stress associated with the pressure to lose weight, or potentially the physiologic damage of perpetually weight cycling, gaining and losing, and the stress that has on the body, and changes to hormones and things like that. So, like I said, there's obviously a million directions to go with this, and we really need to focus on the psychosocial side of things with these future doctors in this article.
Right. Yeah, and I think sort of in addition to the factors that you mentioned in terms of healthcare is, the worst, the weight associated with some certain health outcomes, the undesirable health outcomes and so on, is, you mentioned a few factors that might play into that are psychosocial factors, not direct medical factors. But another one that I think is very important is this idea that many health professionals get the idea that because they feel there's this strong association between undesirable health outcomes and a lot of fat in their body, that therefore they don't have to treat what the patient is presenting with. It's like, whatever it is you came in with, look at this weight. Oh my gosh, your BMI is off the charts. So let's do, glucose test. Let's check your blood pressure. Let's do all these things, and kind of ignore the thing that the person is actually coming to get help with. And then the explanation is, well, yes, of course you have this issue because you're overweight.
Yeah.
You have that issue because you're overweight. If you lose weight, you'll see this will probably get better. And then we'll look at it and see, if it needs treatment or something. And that seems pretty backwards to me.
That's a very common sequence of events when people present for like knee pain or something like that. It's just automatically assumed, well, like that, because the research studies have shown that a 5 to 10 pound weight loss can reduce load on the knee. Sure, but I know countless numbers of people that have knee pain that are very thin, and you would never treat them that same way. That you dive deep on diagnostic and, tested biomechanical testing and things like that to try to find out, well, what's causing their pain, because there's, no assumption there that the weight is the issue. So, patients that are classified as by BMI as overweight or obese, it's like the first, that whole, when you hear hoofbeats, think horses, but that's just not fair. So.
Right. Yeah. It's more, it's the other sort of mistake that we make, I think, besides, if you hear hoofbeats, it must be horses. The other one is, correlation versus causation. And I think we've fallen into that trap
Absolutely.
of that. It's in a recent episode, I talked about some research that was done with plaque in the brain relative to Alzheimer's disease, and how for a long time we assumed that plaque was the problem. If we get rid of the plaque, then we'll reduce the effects of Alzheimer's disease or maybe slow its progression or something. And we're finding out, no, that's not doing it. That the plaque is a result of whatever pathology is going on. It's not the cause of it. Right. And I think maybe we're going to find that out about a lot of these correlations between health and having a lot of body fat. But we're starting to go down that rabbit hole, I think, trying to figure it out.
I know.
We're not in a position to figure it out anyway.
I almost started to talk about inflammation. So there you go.
There we go. And then that can lead us in a lot of directions too. So
exactly.
But, coming back to the, and I think we ought to acknowledge here that I brought it up. I'm guilty of this. I brought up the BMI thing because they were using BMI labels in the paper of overweight. And actually, I was a little surprised that they said that they talked about body donors with overweight and with obesity. In other words, sort of labeling them according to that BMI chart, which we know is very problematic in so many ways. Even just looking at the history of, how BMI developed and has changed over the years, and sort of really entrenching that weight stigma and really leading, I think, a lot of health professionals down that road of correlation as opposed to causation. But it's there. I mean, BMI is there, and we have to deal with it. And those are the labels that often we have, as opposed to some alternative system, which is yet to be developed. So, that's a conversation I always have with my students is, here's what BMI is. You need to know what BMI is. You need to know it's being used, but you need to know it's got all kinds of problems, and that we're not, this is still in flux. This is, a lot more science to do before we figure this out.
Well, it's great that you do that, because I would imagine most don't, because we're not taught differently. We're not taught differently. And, you go to a doctor and you get your discharge summary, and it'll say what your BMI is at the top of the paper. For some people, it might say morbidly obese at the top. It's like, well, that's a fun take home, right? But with no
love that label,
but with no nuance. And again, not to go down the rabbit hole, but another danger then is assuming that people that are normal BMI aren't having healthcare issues, right? There's so much that you could go, that anyone that's interested could read about with this, but there's just basically a strong association between internalized weight stigma and poor health. And what that means is internalized weight stigma is essentially feeling that, you are less valuable if you are in a larger body. And you could be in a very thin body and have a high level of internalized weight stigma and potentially consume quite a bit of healthcare dollars because of the, maybe the poor behaviors you're engaging with to suppress your weight. So another assumption that I bring that up, because another assumption that's often made about people in larger bodies is that they're like burdening the healthcare system. And that's just not there. It's not true in the literature. That one of the biggest healthcare burdens is diabetic care, but it's like wound care for diabetes when things have gone gone on a very, very long time. So that's also something that I think is really important for people to hear and realize, and it's definitely relevant to this paper, because these are, again, future doctors. And over in many places throughout, in the themes that emerged from this, that they discovered is that they connected, the difficulty of dissecting larger cadavers to frustrations faced by healthcare providers, and didn't cite any socioeconomic or biologic factors for the larger bodies of the cadavers. They felt strongly that obesity was a controllable state that could be managed. So even though, if that were, most people regain any weight they lost, and pretty quickly. So are we all that weak-willed, or, is there so much more going on that we're just not willing to engage with?
I choose B. I think there's there's more going on than we know about, and that we're, like you say, willing to engage with. We'll be right back with more of this conversation. Marketing support for this podcast is provided by HAPS, the Human Anatomy and Physiology Society, promoting excellence in the teaching of human anatomy and physiology for, over 30 years. Hey, are you going to the HAPS annual conference? If you are, you really need to check out the schedule of workshops. It's awesome. Yeah, okay, I'm giving one of the workshops. But I also want to mention that Krista Rumpolsky is presenting an important workshop on weight stigma that you don't want to miss. Go visit HAPS at theapprofessor.org/HAPS. That's HAPS to find out more.
Kevin, I'm curious, to hear about your experiences, because obviously, your first cadaver course would have been a long time ago, and I'm sure you've taught in cadaver labs. What's been your what were your personal feelings about this article as you read it? Based on your history.
Yeah, I to be honest, a lot of the cadavers that were around when I was studying anatomy, there weren't that many that were overweight compared to what you see in
things are changing.
Cadaver lab these days. And I wonder how much of that, though, had to do with the availability of body donors and donated bodies, because, I think that there were more than we could use, and so choices were made about which ones would be used for education. And so that sort of gets into this idea of the perfect body donor and the desirable body donor, as opposed to the difficult or undesirable body donor. And so we didn't really have that many, but there was, when we did have body donors with a high, fat ratio, there were issues with that. And that was a useful thing to learn about that. I don't remember some of the comments that were made in this paper, recorded in this paper, I should say, from faculty that were very dismissive of those fatty bodies, and how difficult, or time consuming it was, to dissect them, how difficult it was to find certain structures and isolate them and so on. I don't recall that, but you know what? I don't know that these students that in this group would have recalled that. Some of them did. Some of them remembered that, but I bet you a lot of them just, it like went in one ear and out the other, but not in the sense that they didn't pay attention. I think at least subconsciously they did. And that informed their growing weight bias, their bias against the high fat content. And so I suspect that some of that happened to me, without realizing that's what was going on, because, you're affected by your environment.
Absolutely.
In terms of, your social environment. So,
I think, and not this is a whole other road to go down, but I think, the social events of the past year in our country have shown us that it is not enough to just be neutral or silent about an issue. Bias and stigma will continue to exist and grow if you say nothing and do nothing. So I think that just realizing that students are in our very fat phobic culture, students are going to come in set up for this experience. And if we don't talk about it, and address it and try to, counteract it as a faculty, if for no other reason than to continue to reinforce the respect and appreciation we say we have for these donors and to be able to study anatomy, then it's not surprising that these results are what they are. So we need to find, I believe that, and I certainly will be doing this, when I teach my gross anatomy course to PT students, I will be talking about fat quite a bit, and realizing that, yes, look at our textbook images. They're almost always, right, a very muscular white guy, right? Like there's no hiding that, right? And even in like in like labs where they'll be like palpating each other and for looking for bony structures and things like that. Most PT students are like, not to make a generalization, but a lot of PT students are fit or thinner. Many times because, they're also very, into exercise, but also feel pressure to look a certain way for patients to listen to them. And doctors do as well. So they are not going to be in school like palpating larger bodies. And like, we need to give them a better, we need to talk about those things up front, and not be silent about it, and realize that they can either very overtly or subconsciously turn away patients in larger bodies just by kind of the subtle messaging or attitudes that they have towards them. One line from the discussion was that the students saw difficult bodies as less educationally valuable. And how concerning that is, because that really echoes that narrative that we see of the difficult patient. So what impact might that have on their care? So when I gave a guest lecture on weight stigma to a group of physical therapy students, many students were sharing stories of patients feeling just totally beaten down by the healthcare system, that everything is due to their weight. And, and the smallest, saying something the wrong way or the smallest interaction can mean you never see that patient again, and then there's certainly no way to help them at that point. So, like I said, so many roads to go down,
right.
Because I think this article or any article talking about weight stigma and weight bias today is going to raise, I should say, I don't know who could be listening that doesn't have an emotional response to this, whether that response is, oh, well, it's ridiculous. Like, being overweight or obese is the cause of all these diseases and people should feel stigmatized, or, this has been my experience in my life. I was in a larger body at a team dissecting, and while they're complaining about working with fat, I'm standing there thinking, what would they think about me? And that is so echoed in these students' comments about, generating negative attitudes towards their own weight, their own body image, feeling disgusted by their body fat. It's just, it's heavy. It's very heavy. And weight is such a very personal issue. So I don't know who could have lived long enough to be listening to a podcast that hasn't unaffected by this topic in some way.
Right, exactly. And I don't know, it's kind of an area that I think a lot of us need to grow. I mean, all of us have biases of various sorts.
Sure.
And it's what we do with them and what we do to counteract the biases that are harmful biases. Yeah. And just as a big fan of transparency, something that really struck me as I was reading this paper about, desirable versus difficult or undesirable body donors to work on. I remember way back in an earlier episode, I think I wrote it down in my notes here, as episode 29. Yeah. It was titled The Silent Teacher. And it was a conversation with Aaron Fried, who's works with body donors with his students at Mohawk Valley Community College. And we were talking about that. And I said that, when I got to middle age, I signed up for a program where I was doing resistance training every week. And then I got to twice a week doing resistance training with the idea of making my skeleton and muscles stronger is kind of a health thing to improve my body framework as I age, because that's an issue with bone loss and muscle wasting and things like that. But I said in that episode that something that I often have in mind as I do it is, especially to kind of motivate myself when it's hard and almost painful to keep going, I'll say to myself, yeah, but when I'm a body donor, and I am registered as a body donor with a local medical school, when those students get my body, they're going to love it. They're going to fight over who gets to dissect me. That's my goal. And then I realized that, I never thought of myself as having an issue about my body image. But I do. I mean, we all have our own body image. And I think there are certain things about our body image that we either like or don't like or want to be better, even if it's good. And that's, for me, that, brought up that, oh my gosh, and if I talk about it that way with my students, am I sort of increasing the likelihood that they're going to see those with more well-defined muscles as good and those with less well-defined muscles as bad? And of course, there are different reasons for that. Some body donors are very elderly and have experienced some of that muscle wasting. So it has nothing to do with their, fitness exactly. I mean, it's more about their age than their general, fitness approach in that. And it never has anything to do with a person's character. And that's what we've made it.
Yeah,
and I noticed that when, the few times this has come up in live classes with students in the past where we talk about fatness, people are much more willing to denigrate fatness or fat people when they're 2 feet away from someone that is fat. And, we're a lot, if we have biases about race or ethnicity or ableness or other things, we're a lot more circumspect about what we say and how we say it. But with weight stigma, we're not shy about that.
I mentioned in the intro that there was a 2014 study by Phelan, Phelan, and everyone can look that up. It was the first and largest sample of medical students. And they found that the levels of weight bias were higher than racial bias, bias against poor individuals, and bias against LGBTQ. And, that might be shocking at first, but then you think, well, the assumption is weight is controllable. You can't control your race, or your sexual orientation and things like that. So it makes sense when you frame it that way, right? That it's that controllable issue. Where I always give the analogy, we put humans on this BMI scale, but there's many breeds of dog, right? And you could feed a bulldog and a greyhound. So you imagine very different looking dogs, the same diet, make them exercise the same amount, and they're still going to look like a bulldog and a greyhound.
Right. We
do not apply that to people. So it's not possible that someone's natural body size is larger, whether based on frame or, muscle or just the genetic factors there. Because we all know individuals, we're going down that wormhole, but I'm going with it. We all know individuals that basically don't have dietary restrictions and have always been thin, and vice versa. But for some reason, that makes us so uncomfortable. And I just think that it's the weight loss industry and its long history, and then how muddled it got with health. Because, absolutely, there is I'm not here to deny that there's correlation between high body weight and health and disease, right? Nobody can possibly deny that. But it's almost like we're unwilling to tease that apart because we want a simpler answer. Yeah.
Right. Yeah. And that controllable thing really stuck out to me in this paper is that, there came a point in the paper where they talked about how the student attitudes were that, wow, this was a good learning experience to have these body donors with all this fat. And I learned about, there's two different things going on here. One is they learned about how much damage it does to the body, which puzzled me because you can see that in a dissection. No. What?
No.
What you see is, you see organs that are infiltrated with fat, as compared to the prosection where they picked, the so-called perfect body donor. And there isn't all that fat infiltrated in and making it difficult to find this nerve or that nerve or this blood vessel or that part of the organ or whatever. And so they're making this assumption that because it was difficult to find or it didn't look like it does in the textbook or in the prosected specimen, that therefore that organ is damaged, that body is damaged. Look at all the havoc this is wreaked. No, there's just more packing material in there, and it's harder to find it in that extra packing material. I mean, that's really all you can say at that point. Now, I'm not saying that there hasn't been any damage. Maybe there has. I don't know. But they can't say that. So they're
No.
assuming that. And then they apply it and say, boy, if my patients could see this, boy, then they would control their weight.
Yeah.
And that gets back to this old, I need a sound effect for control, the word controllable whenever it comes up because, like alarm bells or something, because it's not controllable by, I don't think, this is my opinion based on what I've seen. I don't think it is controllable for many people, their body weight, because as you say, there are other factors like genetics, and other things too. It's not just that, not just genetics, but that's probably a big component.
It makes me wonder if it would be valuable for students to take some sort of pathology course before dissecting, because then they would know what disease looks like in a cadaver, whether it's plaques or clear signs of a lifetime of long smoking, enlarge, to see what cancer looks like that's spread throughout the body. They have no idea. And, you mentioned the plaque, the discussion about plaque and dementia. I just know from doing some textbook work that, they're seeing those strong, the APO4 gene, that it's really about that chronic inflammation genes. And that's going to be completely independent of body weight. So, from a personal story, I have so many, but my father, his older brother, and he all had heart attacks at age 56. All tall, thin men. My dad was a mailman, so he was walking 7 miles a day. And if he wasn't walking his route, he was walking the golf course. Didn't smoke, didn't drink, ate a low-fat diet. Had a heart attack at 56 and a double bypass at 69. So, but it's well, we want to look at that as the exception, right? And or that person just got unlucky somehow, rather than, oh, there's more going on here,
right?
Exactly. That we don't really understand. So that assumption, like you said, that just because there's fat infiltrating things, that automatically means the bodies are ruined, or that the bodies are unhealthy, rather than, it's just got to go somewhere,
right.
Rather than being, and, just on a personal side note, when dissecting, I've often found some of the best specimens or, best organs or really large, thick musculature in larger bodies, provided that they weren't potentially very inactive, because then you will get that muscle atrophy as well. But I'll never forget, the first cadaver I dissected was a larger man, but young. He was 56 and worked, you could tell he was definitely a heavy laborer, and his muscles were incredible, but we had to get to them, for certain,
yeah.
But it was very worthwhile in that sense. We had the best samples of every muscle, because, obviously having a higher level of body fat requires, if you're active, requires more muscle expenditure. So, so just some thoughts there. When you're talking about, I want to mention, when you're talking about your personal, kind of history with thinking about, the lab and BMI and things, it made me think of when I was, so I had to get, mentioned I just had my son, and he came 4 weeks early. I went into labor, and for hours, because I have such a high pain tolerance, was just just have a bad stomachache today. But at any rate, my son was breech and did not turn the whole time. He's as stubborn as me. The whole pregnancy, head was under my right side of my diaphragm and his butt was in my pelvis. So I knew I thought I was going to get a scheduled C-section, but it ended up being, emergent. And I both 2 times in the whirlwind of, they get you on the table and they're throwing you around, just basically, I think, so you don't have time to get scared. As soon as they undraped me, and I, bent over for the lumbar puncture, the anesthesiologist's first words were oh, look at those spinous processes. Oh, you're making this so easy on us. Right. Yeah. And then they did a nerve block, a lumbosacral plexus nerve block of the iliohypogastric and ilioinguinal nerves, because that really helps with pain post C-section, because of all that, they're separating your abdominal wall. And so they're trying to numb those, and those nerve blocks last about 3 days. And it was on the dot when that wore off. But he was just God, I could see your ribs. He said, we love our thin patients. They make everything so much easier on us. And I'm laying there in the middle of the C-section, and my son's about to be born, and all I could think is, you
Yeah, right, exactly.
I'm getting mad and I almost want to say something. I'm like, no, he's got a massive needle in my side. I'm going to just lay here. But, like, God, it's like, oh, so like, if they're overly praising, like someone in a smaller body, like, I'm sure they're not outright saying, man, you're making this hard on us, to someone in a larger body. But what are they saying or not saying? Or, what is the dialogue that might make that person feel badly? So I don't, that just reminded me of that from that experience. And it is living proof of what these students are saying in this paper,
Exactly. And, the other thing that could have been happening, though, is, in your situation, okay, they're praising the thinness of your body in terms of its, their with the procedures they have to do.
Yeah.
But who else is in the room?
Exactly.
I mean, is there, a nurse or another, any of the health professional team there that might not be thin and might be taking that to heart, and what is that doing to them? And I think that kind of comes back to this idea of, and something else that you mentioned earlier along with it, and that is the idea that maybe they should take pathophysiology or pathology or something first before they do this, and that kind of emphasizes that dissections, and we're talking here about body donor dissections. But I think this is true, at any beginning level anatomy and or physiology course, but of course, especially the anatomy part of it. Whether you're doing human body donor dissections or not, you're still looking at specimens, maybe photographs or digital models and different things like that. And I want to circle back to that in a second as well. But this is at the beginning of their process of learning to be a health professional. And I think there's a responsibility, therefore, on those of us that teach these beginning courses to really consider establishing those attitudes, or not establishing, but mentoring our students in attitudes and showing them maybe a mirror up to what their existing attitudes are, and modeling attitudes that are more helpful for health professionals, and not saying things like that you experience.
Easier to start than stop something.
Right.
Like, I mean, like the foundations, think about going really broad here, our early childhood years are absolutely most formative in who we are, how we see the world, our like long-term anxiety and, issues and things like that. And so if this is taught and infused at the beginning of a curriculum, there's far less chance for it to stick in later years. But if it's never addressed, if you have assumptions for years and years and years, it's extremely hard to undo those in any aspect, because it's not only, you've been told one thing forever, but it's also, I think, very personal and jarring to be confronted with your own bias, again, in any aspect. And a natural reaction is to get reflexively defensive, because no one wants to be labeled someone that is biased or stigmatizes someone. So that's...
Well, I think that's the first thing we need to get over as instructors, as people. Is that, I have biases. I have, concerns about my body image. I have, I have ways of communicating that are not only not helpful, but are destructive sometimes. Yeah. And so, my goal is to continually improve when I see those. But man, it hurts when I see that, when I'm faced with something like that. And I do get, I think, as you said, we all get defensive when that happens. But I think, reading this paper and thinking about these things and maybe exploring it a little bit more, beyond that. And I'm glad that HAPS is working on this, among other issues of inclusion and diversity and so on. And those are all helpful things that are going to help us be good models for our students. And maybe think about statements that we make that maybe can avoid it. And just kind of weaving in something I said I'd circle back to, so I guess I better. And that is, that's something that as a textbook author, I'm trying to incorporate more diversity in the representations of the human body that are presented in our books. And I think all of the A&P authors, because I've had conversations with a lot of them, are doing the same sort of thing, and that's great. I think we also need to look at some of these other things that represent the perfect body, and that would be even plastic models that we use in the lab. It would be, digital. I mentioned this a few minutes ago, digital cadavers or body donors that we use in these digital products are often, the best example. It's like with histology slides. We always show them the best example. And then when they go looking for it, it's like,
as it is.
None of them look like this. Well, no, that's because we showed you the ideal one, the easy one. Oh. And so, are we doing that to our students, sort of setting up this false ideal just in the learning tools that we use and in the learning environment that we set up for our students. So, I think it is incumbent upon us doing the anatomy to actually do that part of it. And I've heard this comment, not often, but when this has come up, I've heard the comment of, well, that's why students take humanities courses. Yeah. That's where they learn it. And well, yeah, some of it, humanities courses are very valuable. And I think that is part of it. But we have to bring that into the anatomy. I mean, it does no good sitting over there in a humanities course without pulling it into our anatomy course.
I mean, what's more of a humanistic course than anatomy? Like, it's that's a lot of weight to put on that humanities professor, and that's assuming that they could possibly cover every nuance of what humanities or ethical treatment of patients or responsibility is. I decided to, like I said, I'm teaching PT students for the first time in a couple of weeks, and I'm their gross anatomy instructor. And their first assignment in the first week is to choose between 3 different articles that talk about either the, kind of like the history of body donation and the inherent inequality in that, or kind of like all the issues with representation in textbooks. Or there was an article about that lack of representation and how that could lead to both the perpetuation of like some beliefs about, diseases being associated with certain races, or, not understanding differences across ethnicities and races and bodies, because we only have, the like white male, very, very often. So like their first assignment is to basically do a reflection on that before we teach them a single nerve or muscle or things like that. And, I'm sure I'll talk about weight bias and other things that come up throughout, but it's such a personal course. Because nobody can take an anatomy course or physiology, but I think anatomy just hits a little closer and not think about their own body. It's impossible. Like you said, with the fact that you think about like, what kind of cadaver will I be when you're strength training? I'm not. Maybe I just haven't gotten old enough yet to be thinking about that. But what's funny about that, Kevin, isn't it still speaks to control, because you could fall ill with a disease and all that muscle waste away in 2 months. You know what I mean? Now, not saying don't do it, obviously, but like that's just speaks to us believing, our need to control.
Right, and, exactly. Well, Krista, this has been a great conversation, and we haven't even covered half of what we could talk about.
Read the paper.
Read. So please do read the paper. It was very worthwhile, and share this episode with friends of yours that teach anatomy or anatomy and physiology or even general bio and so on, to get that conversation started. Talk to them about it. And I think that's the only way we're going to start to see broader change. Now, Krista, you talked about doing some things in your course, but we need to all start to go down that road.
I agree. Just as a little plug, if anyone's attending the virtual HAPS conference at the end of the month, I'm doing a workshop on the value of talking about and addressing weight stigma in the classroom as a workshop on Wednesday. So you'll find that on the schedule. If anyone wants to hear more about it, talk about it, tell me I'm wrong, whatever that might be in real time. Yeah, I can take it. That's for sure where this is concerned. So.
All right. Well, this has been great. And I'm sure that in future episodes, we'll be revisiting this topic. It's an important one. And please do, call in, send emails or whatever with ideas that you have about
Absolutely.
this. And maybe we'll come back with a different journal article where we can look at a different aspect of this in some future episode. But Krista, thank you for once again bringing us a great article and some great insights.
No problem. Happy to do it.
There is just so much we need to explore and talk about related to weight stigma. An easy way to start that conversation with folks in your network is to share this episode with them and ask them for their thoughts. The easiest way to do that is to go to the approfessor.org/refer to get a personalized share link that will not only get your friends all set up, it'll also get you on your way to earning a cash reward. And if you don't see live links in your podcast player, go to the show notes at the episode page at the approfessor.org/93, where you can explore the paper we discussed in this episode. And while you're there, you can claim your digital credential for engaging with this episode. You're always encouraged to call in with your questions and comments and ideas at the podcast hotline. That's 1-833-LION-DEN or 1-833-546-6336. Or send a recording or written message to podcast@theapprofessor.org. You're invited to join my private A&P teaching community way off the social platforms at the approfessor.org/community. Hey, I'll see you down the road.
The A&P Professor is hosted by Dr. Kevin Patton, an award-winning professor and textbook author in human anatomy and physiology.
This episode should only be listened to by those for whom it was intended.